Can you answer this USMLE question? If not, then let's break down this mind map and you'll know the answer in 5 minutes. In this video, we'll cover diagnosis, complications, and secondary prevention. When a patient presents with stroke symptoms, we need a systematic approach to diagnosis. This includes clinical assessment, imaging, vascular imaging, and laboratory tests. Let's go through each component. Clinical assessment begins with a thorough history and neurological examination. The history should focus on the time of symptom onset, which is critical for treatment decisions. The neurological examination helps localize the lesion and assess severity using scales like the NIHSS. All stroke patients need basic laboratory tests. This includes CBC to assess blood counts, PTINR and PTT for coagulation status, blood glucose to rule out hypoglycemia as a stroke mimic, electrolytes to check for sodium abnormalities, and renal and liver function tests. A cardiac workup is essential to identify cardioembolic sources. This includes ECG to look for arrhythmias like atrial fibrillation or signs of MI, cardiac enzymes such as troponin, and echocardiography to assess for structural heart disease, valvular abnormalities, or intracardiac thrombus. The most high-yield part of diagnosis is imaging. CT scan is the first-line imaging in the emergency setting. CT has several advantages. It's fast, taking only minutes, it's readily available in most emergency departments, and it's excellent for detecting hemorrhage. In early ischemic stroke, the CT may show loss of grade Y differentiation, so-called effacement, and the hyperdense vessel sign. Importantly, the CT may be completely normal in the first few hours. In late ischemic stroke, you'll see a hypodense area representing the infarcted tissue. The main purposes are to distinguish ischemic from hemorrhagic stroke, rule out hemorrhage before giving thrombolysis, and identify stroke mimics. Remember, hemorrhage appears bright white or hyperdense on CT. MRI with diffusion-weighted imaging is more sensitive than CT for acute ischemia. As shown in this image, MRI can detect ischemia within minutes of onset. It's better for detecting small infarcts and is especially useful for posterior circulation strokes. It can also distinguish new strokes from old ones. However, MRI has some disadvantages. It takes longer, usually 30 to 60 minutes. It's not always available, especially in emergency settings, and it has contraindications including pacemakers and metal implants. After initial brain imaging, we need vascular imaging. The two main options are CT angiography and MR angiography. The purposes of vascular imaging are to guide thrombectomy decisions by identifying large vessel occlusions, identify carotid stenosis that may need intervention, and detect aneurysm or vascular malformations. Okay, now let's discuss complications, which are divided into acute and chronic complications. Cerebral edema typically develops 24 to 72 hours after stroke onset. Severe edema can cause mass effect and midline shift. Treatment includes osmotic therapy with mannitol or hypertonic saline, and in severe cases, decompressive craniectomy. Hemorrhagic transformation occurs when blood leaks into the infarcted tissue. Management is mainly supportive care. Seizures can occur in acute phase. The preferred treatment is levetiracetam. Patients with dysphagia are at risk for aspiration pneumonia. Keep patients MPO until swallow assessment is complete and treat with antibiotics if pneumonia develops. Immobilized stroke patients are at risk for deep vein thrombosis and pulmonary embolism. Prophylaxis with subcutaneous heparin or sequential compression devices is important. Chronic complications include depression, which is very common after stroke. Cognitive impairment may persist. Spasticity can develop in paralyzed limbs, and chronic pain syndromes, including central post-stroke pain, can occur. After a patient recovers from acute stroke, secondary prevention is crucial to prevent recurrence. This includes lifestyle modifications, antiplatelet or anticoagulation therapy, statin therapy, blood pressure control, diabetes management, and carotid revascularization when indicated. Lifestyle changes include smoking cessation, regular exercise, weight loss if overweight, and a healthy diet. For non-cardioembolic strokes, use aspirin or clopidogrel for long-term prevention. For cardioembolic strokes or patients with atrial fibrillation, use anticoagulation with DOACs, such as apixaban, rivaroxaban, or dabigatran, or warfarin with target INR of 2 to 3. All stroke patients should receive high-intensity statin therapy. The preferred regimen is atorvastatin 80 mg daily. The target LDL cholesterol is less than 70. Target blood pressure is less than 140/90. ACE inhibitors or ARBs are preferred agents. If a patient has 70% or greater symptomatic carotid stenosis, consider carotid revascularization. Options include carotid endarterectomy or carotid artery stenting. To summarize, ischemic stroke diagnosis relies on clinical assessment, CT scan as first-line imaging, MRI for more sensitive detection, vascular imaging, and appropriate laboratory tests. Complications can be acute, like cerebral edema or hemorrhagic transformation, or chronic, like depression and spasticity. Secondary prevention is crucial and includes lifestyle modifications, appropriate antiplatelet or anticoagulation therapy, statin therapy, blood pressure control, diabetes management, and carotid revascularization when indicated. Thank you for attention. In the next video, we'll cover the acute management of ischemic stroke. If you found this helpful, please like and subscribe to BenMed Academy.